Good morning, everyone. I'm Kimberly Chalia with PHCA. Thanks so much for joining us for today's webinar. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for all attendees. For those who provided an AB number, credits will be uploaded in the next 2 to 3 weeks. As we begin today, all attendees should be in listen-only mode. Please feel free to submit any questions you may have utilizing the chat icon at the bottom of your screen, and we'll make sure to answer as many of those questions at the end of today's presentation. I'll now turn it over to Jennifer.
Well, good morning, and thank you, Kim. This morning, we're going to discuss departmental considerations in infection prevention and control. I think it's very important for all departments to be a part of the infection control group and to ensure that they know how their contributions assist in making sure that our residents are kept safe. Just going through the objectives. So the first thing is looking at pathogen transmission. They need to know that there are sources of infectious agents with an exit portal, a mode of transmission, which can be us, and then the susceptible host with an entry portal, which would be our residents. The types of infections are bacterial, viruses, fungal, molds, or protozoa are the same thing. So our goal as healthcare providers is to break that chain. Germs are present on our skin and within our bodies. Additionally, germs can be found in the air, on surfaces in the environment, and sometimes in food and water. They can enter a person's body through mucous membranes, such as the nose, eyes, or mouth, as well as through breaks in the skin or via a catheter or tube. So how do infections spread? Well, if hands, surfaces, and equipment are not properly cleaned and disinfected, germs can spread to others or into the environment. And then we have person to person, the coughing or sneezing into the air, which no matter how many times you go to the store, I see this all the time. Touching other people or surfaces without washing hands, and then touching of the body fluids or secretions. So we all get caught up in completing our tasks and taking care of our residents, but we must remember that infection prevention is also a part of our jobs. So hold each other accountable. If you see something wrong, say something. I used to have little cards that just had like a germ on it. And if I would see somebody not washing their hands or going in and out of a resident room without using the hand sanitizer, I would give them a little germ card. That way I'm not confronting that person, or it's not punitive by any means, but it was just a little reminder. A lot of times when you tell somebody, hey, I saw you didn't wash your hands when you came out or use the hand sanitizer, they think they're either getting in trouble or you're picking on them. So I would use something like a little germ and just kind of hand it to them as a little, hey, FYI, we need to continue to wash our hands and do what we need to do. That seemed to come over a little better with staff, but there are various other ways of doing it. But I also have each staff member holding each other accountable, because I can't be there 24/7. I have also had on each shift where I had like an infection prevention guru on each shift in each department, and they would also help to keep everyone accountable. So why is this important for us? Well, 1 to 3 million in serious infections every year in long-term care. That's a lot. As many as 380,000 patients die. Infections are the most frequent reasons long-term care residents get admitted to hospitals. Many healthcare-associated infections are preventable with current recommendations. 40% of healthcare personnel adhere to hand hygiene. That means 60% do not. There's insufficient infection control infrastructures in non-acute care settings. 1 in 25 hospitalized residents or patients contract an HAI. That's also important for us to be aware of because we're bringing these residents into our buildings. So they may be coming to us without a diagnosis of an HAI, but we need to monitor them, for the first 72 hours because they could have contracted something in the hospital. So it definitely is a team approach. My housekeepers throughout the years, and my mother has been a housekeeper for over 40 years, she would know these residents inside and out because as they're in cleaning the rooms, they would be talking to the residents and, gain a rapport and see these residents every day. So if one of them comes to me and says a resident has potential signs or symptoms of an infection, I'm going to look into it. So it takes all of us, again, we're always in the hustle and bustle every day. Sometimes we don't get that chance to ask the resident how they're feeling. We don't really pay attention to the observations. That's why there's an interdisciplinary approach because we all see things from a different perspective. The number one preventative measure we can do is hand hygiene. And I know that when we do hand hygiene, it is not always being done correctly. A lot of times there's the missing area on the palms, around the thumbs, between the fingers. But we need to be quite aware that it's the friction that helps us. So it's not just putting soap on your hands, rubbing it under the water and moving on. You need to be aware, are you retouching the faucet? When you grab paper towels, are you touching something else and you're recontaminating your hands? So hand hygiene really prevents the spread of pathogens. And I know people say, we don't have time for this. We don't have time for that. But really, we have time, especially with using alcohol-based hand rubs. So healthcare workers should wash their hands before direct resident care or donning of gloves. After removing the gloves, I can't tell you how many people have told me, well, I wore gloves. My hands aren't dirty. No, you still need to use hand hygiene after the gloves. After contact with a resident or visitor, skin or personal items, if they're visibly soiled, before and after bathroom use, and before and after eating. ABHR, they're great. They really are. CDC actually recommends using ABHR more than hand washing because they are able to kill more bacteria than hand washing alone. So you want to use an ABHR except for when your hands are visibly dirty or contaminated. And in the event you're working with a resident or in a residence area that has C. diff or the norovirus, it is more important to use hand washing techniques in that case. But dispensers can be placed at the point of care, so they're more accessible. And they're less damaging to the skin than soap and water. And I know when you wash your hands a lot, especially in the winter time, our hands break down. You start to get cracks. So you also want to make sure that you use some form of moisturizer that does not attract bacterium. So I always used a hand moisturizer that had an antibacterial in it because, again, that's going to be a portal of entry. So those people that say, I didn't touch the patient. Well, there's bacteria that survive for days on equipment. Surfaces in the patient care environment, including bed rails, IV pumps, call bells, TV remotes, bed controls, and the computer keyboards that we use for our charting are often contaminated. It's important to practice that hygiene after you leave a room, even if you only touch the patient care equipment or other surfaces. How many times does somebody go in to answer a call bell and they think they're just asking a question, but they end up handing the resident something? They're touching that equipment. So we want to look at cleaning versus disinfection. Cleaning is the process of physically removing the germs, the dirt, the impurities. Disinfecting is killing those germs. So cleaning and disinfecting are two different procedures that should be used together to remove and kill those germs. If the surface is not cleaned first, germs can hide under soils, and then the disinfectant is not working properly. And remember that all products should be used per manufacturer guidelines. So anything that we use in our facilities, of course, should have an SDS sheet, and we should be checking on how the manufacturer is telling us to utilize it. One of the big things is the contact or the dwell time. This is the total time required for a healthcare disinfectant to remain in contact with the environmental surface to inactivate all labeled microorganisms, which means it needs to stay on for a certain amount of time before anybody were to wipe it off, or it's ineffective. A lot of times we say, let it air dry. That's a lot better because we're not wiping off the disinfectant, in which it would no longer be effective. So contact time can vary according to the product and according to the organism for concern. Again, it's very important for us to follow those manufacturer guidelines. You can't just, say wipe off a bed rail and then come back with a dry cloth and dry it. That's not going to be enough dry time. And I know that we don't have the time to wait for things to dry, but we have to follow this or everything that we're doing is really moot. Our cleaning basics, outside to inside. Start at the door and move forward. Clean to dirtier, proceed from the cleaner area to the dirty area, so we're not spreading the dirty areas into the clean. And then from high to low. You want to start towards the ceiling and work your way down to the floor because things fall. The terminal cleaning sequence, you want to start with shared equipment and common areas, and then proceed to the surfaces and items touched by the residents. High touch surfaces outside the patient zone should be cleaned before the high touch surfaces inside the patient zone. And then clean general patient areas that are not under transmission-based precautions before those areas under transmission-based precautions. And again, common sense is telling us we don't want to have to take infections from room to room because we started with, somebody in isolation and then moved on. Everybody has the responsibility to clean. And I know people are probably rolling their eyes right now because it is an ongoing battle, but every department has to help with the cleaning process, whether it is, just taking a rag with a disinfectant and helping to wipe down the rails, or wipe down, even if you in your office, wipe down the doorknobs. I can't tell you how many times residents would just go past my office and would just try and see if they could get in my door. Clean that as well, because you don't know who has been touching it and what they're taking with them. Use fresh cleaning cloths at the start of each cleaning session. Change cleaning cloths when they're no longer saturated with your solution. Ensure there are enough cleaning cloths to complete the required cleaning. A lot of this was environmental related, just breaking down into other considerations. For activities, residents should wash their hands before and after group activities. How often do we see that? Residents can also use ABHR as long as you're monitoring them. Some have a habit of trying to drink it or something of that sort, but just monitor them. Let's do this before we start our activity for the day. Let's do this before we go back to your room. The disinfection of items. We do utilize shared items when we do activities like bingo, the bingo chips or the cards. Make sure that all of these items are able to be disinfected. So we don't want to use paper. We want to make sure they're laminated so they can be wiped off, stuff like that. And we'll also talk about proper food technique when we get to dietary, but it's also important for activities to consider this as well. If you do activities with foods, you want to make sure that you have the proper food technique. Animal care. If you have pets in-house or if somebody brings their pets in, of course, you have to have that as part of your policy and procedure. But make sure that residents are washing their hands after holding a resident or an animal or touching an animal of any sort. You don't know what the animal could be carrying, even if they don't appear sick. And residents should not be involved with excrement care because, their excrement, of course, can have different protozoa organisms in it. So that should always be up to the resident or the pet owner and not to our, for the staff or the pet owner, not our residents. Dietary, hand washing, of course, is very important. The proper food preparation techniques, and we will go through that a little bit. Covering, labeling, and dating the refrigerating items with an expiration date. When I worked in dietary, that was probably one of the things that you always wanted just to scream about, because we would just put stuff in the refrigerator and move on. We have to make sure that they're covered properly, labeled properly, and have an expiration date. Refrigerated items, 40 degrees or below, they must be covered, and the meats on the bottom shelf in case there's anything that would drip. Do not wipe utensils on your apron or your hands on your apron and then return to dishing out the meals. The thawing of food should be in the refrigerator. If you're going to cook it immediately, you can microwave it for defrost. Try not to do that. Do not leave out at room temperature for extended periods. Your hot foods are supposed to be at 135 or above. Your hot water dishwasher, the wash cycle at 150, the rinse cycle at 160, and the final rinse cycle at 180. The 3-compartment sink, the sanitizer should be in the 3rd compartment. Make sure that the time in the sanitizer solution is for an appropriate amount of time. Again, look at the SDS sheet. How should it be diluted, and how long should the dishes remain in the sanitizer? Your water temp is 75 degrees with 50 ppm if bleach is used. Pots and pans need to be washed in hot water at 170 degrees for 30 seconds. Your cold foods need to be 41 degrees and below. And your freezer should be at 0 or below. Make sure that when we are taking the food and drinks up on the carts, that by the time they get to the resident, they are meeting the appropriate guidelines, because there are foodborne illnesses that we really need to be concerned about as well. These are just some fact sheets. Foodborne illnesses greatly impact residents. One example is the norovirus, which is a common cause of gastroenteritis in the US. So this is some pretty good information from the US Food and Drug Administration that kind of gives us safe food handling, what we need to know. I think it's a good reference to possibly laminate and put in your dietary department. And make sure that your staff who are passing out trays are also aware of this. How many times, are the nurses' aides busy and they'll go feed that other person a little bit later because they take extra time? Well, we need to make sure that their meal times are at the right, their meal temperatures are at the appropriate temperature, or we could be giving them a foodborne illness. And this is just the back of the food facts. This is food safety Making sure that you're not at risk for foodborne illnesses, another good one that I found from the USDA. Again, something that you can put out. Now, the big things that we can get from foodborne illnesses are E. coli, Campylobacter, and Salmonella. Linens, they can become contaminated with potential pathogens through contact. Our linens are dirty once they've been used. We know this. But the one thing that you need to be aware of is when you are removing the contaminated linen, you do not want to put it on the floor. How many times do we see that? It's a constant battle, right? Well, you put them on the floor and now you have the ability to contaminate additional items. Or when they're carrying the dirty linen out, they have it next to their body. Well, now you're contaminating your clothes. And then as you go and maybe you're rolling somebody in their bed later, you have contamination on your clothes, which is now touching the residents or the resident area. So pathogens occur through direct contact with the contaminated linens. They can be aerosolized through sorting and handling of linens. It's very important for everyone to be aware that linens can be a mode of transmission. Also consider those that keep their lab coats in the facility and they don't take them home to be washed. They've been sitting there for how long? And then they put it on and go look at our residents and examine our residents. I'm sure that those lab coats have a lot of bacteria on them. So the components of linen, of course, you have collection, transport, the laundry area, sorting, transport again, and then storage. So it starts with the removal of used linen from the point of use. Remember that if you have hoppers or sinks that you would be using for the very soiled linen, when you would be rinsing them, consider taking those out of the resident care areas because they can aerosolize bacteria from all the spray. Hand linen, you should have your appropriate PPE and minimize. Do not sort or rinse linen at the point of use. Transporting, they should be in a designated bag or appropriate linen container. Use single bags of sufficient strength. Make sure they're leak proof and securely tie or close the bags. Do not drag the bags on the floor. I've seen that so many times. And this is when you can have the interdisciplinary approach as well and talk to each other. And if you are having issues with the bags being dragged or linens not coming down with them tied, what is the barrier? What is stopping us? Any laundry that is done on site should have two areas, a dirty area and a clean area. And that is really for anything that we store on the units. You have to have a clean area and a dirty area. There should not be cross-contamination. Hand hygiene supplies and appropriate PPE should be available, and laundry equipment should be used and maintained according to manufacturer guidelines. Sorting, part of the laundry process, is done to remove any hard objects such as glasses or dentures. All the time you find dentures in laundry, right? The sorting should be done before washing if possible. And the facility policy should indicate when sorting is done. Make sure that you also have an ability to minimize any sharp injuries. I know that I have had a couple of incidents where the person in the laundry area had a needle stick because somebody missed, an insulin pen or something before they sent the laundry downstairs. So we need to be aware that we're not only trying to be cautious for our residents, for ourselves, but our coworkers. Transporting, the clean linens should be prevented from contamination. Use a hamper that's lined or closed. The clean cart can be used if it's covered. Keep the covers down on the clean linen carts. I used to have to go around and close, pull the curtain down on the clean cover carts because it's a lot easier if I can just see what I'm going in to get. And do not put other objects on the clean linen carts, like drinks, boxes of gloves, extra depends or briefs. Do not do any of that. That is supposed to be for clean linen only. Areas, both central and on the units, should be constructed to minimize dust contamination for our clean linens and maintained at a normal room temperature and humidity levels. That's also pretty important, especially this time of year where it's hot inside, it's cold outside. If your linens are stored near a back wall area and you have the door closed, is there moisture back there from condensation? Those are things that we also need to be aware of to make sure that we're not, adding mold to our clean linens. Nursing considerations, stethoscopes, thermometers, oxygen concentrators. I know that this is an ongoing battle, but we all need to be quite aware that our stethoscopes, when you use it on one person, it needs to be disinfected before we go to the next person. The IVs, feeding tubes, oxygen equipment, pulse ox, blood pressure cuffs, glucose monitors. These are all important things that need to be disinfected, cleaned and disinfected, and utilize the appropriate sanitizer or product. A lot of times I would see they would pull out Sandy wipes and use that on everything. Well, you can't use Sandy wipes on computer screens. It will start to break down the plastic. A big thing that was not too many years ago, but a lot of people use alcohol prep pads to clean glucometers or thermometers in between resident use. Alcohol is not an appropriate disinfectant. So these are all things that we need to be aware of. Any resident care equipment that touches the skin needs to be handled appropriately to avoid contamination between you or other residents or other resident surface areas. Make sure that anything that you put in your pocket, I know, as a nurse, I try to put a lot of stuff in my pocket because then I'm ready for about anything, right? Well, once you put something in your pocket, the inside of that pocket is now dirty. So these are all things that we need to be aware of. Non-patient equipment like phones or iPads, those need to be sanitized, cleaned, and disinfected according to manufacturer guidelines so we don't start to break it down. Because what happens when we break down a computer screen or the plastics or something on there, that actually opens it up for bacteria to remain deep in the crevices. So for this webinar, we're not going to go through all the various types of precautions, but it is extremely important for all staff to be aware of the various types, what your facility signs look like, what PPE is required for each isolation. And it doesn't matter if you're entering a room or not to touch the resident, you still need to follow the precaution signs. Again, if I'm just going in to see what a resident wants with their call bell and they're in isolation precautions, I need to follow the procedure before I go in to answer that call bell. But everyone needs to be aware that standard precautions are used for all residents every day. We always told our staff to think that every resident has some infectious disease, and that's why we're doing, following standard precautions. They need to be aware that not all infectious processes have to be reported. For example, If someone has HIV or AIDS, they do not have to legally tell us. So it may not be anywhere in the documentation. When I worked in ICU, I did have a girl with a lot of behavioral problems who did have HIV, and she thought it was fun to throw her excrement at us to see if she could get us infected. So we knew anytime we went in there, we were going to don the appropriate PPE, but we also consider every resident to be infectious. That way we're not doing, we're not taking that chance. Donning and doffing of PPE, the order matters. So make sure that our staff are aware of what order PPE should be donned and then doffed. And the important part of that is if it's not done correctly, especially taking it off, after wearing all of this and doing all of that care, then we can contaminate ourselves. That's why it is of such importance. Gloves, of course, the purpose is to protect our hands from body fluids, blood, mucous membranes. There are various types of gloves, non-sterile and sterile. Staff need to use the appropriate type of glove and the correct size. They need to know that if their glove rips during care or while doing something, they need to change that glove. They need to stop what they're doing and replace that glove. Here's just the donning and removing of gloves for just as an FYI. Additional tips: avoid touching your face. It is inevitable. You get all dressed up to go in and do something, especially with someone in isolation, and your face starts to itch. It's inevitable, but you really need to try and avoid touching your face. Respiratory etiquette, as I said earlier, going into the store and people are coughing and sneezing all over the place. We need to make sure that everyone is aware to cough or sneeze into the crook of your elbow. Promote hand hygiene for residents, visitors, and all staff. So put those signs up at the various hand washing sinks. Remind our residents, hey, did you wash your hands before coming to eat your lunch? Visitors as well. Have them wash their hands before going to see their loved one. It's important for everybody. Covering of open areas on skin. Again, that open area is a portal for infection. Considering everything in our pockets to be dirty. Follow policies and procedures. Now, a big one that is, I know, controversial, but artificial nails, nail polish, and jewelry can spread bacterium. There was a significant MRSA outbreak because a nurse that had fake nails and wasn't using gloves to put eye drops in went from resident to resident with the MRSA between her nail and the fake nail. And every time she went to put eye drops in, she was exposing those residents to the MRSA. It is disgusting. The amount of bacteria that can be around fake nails, especially underneath the nails and under nail polish. Those are significant things that I know I always tried to keep my staff away from having, not only for the resident safety, for the staff member themselves. If you end up getting an infection between your nails, some kind of bacterium, you may not know it, but then, you're moving around and living your life and you have this infection, it could cause problems elsewhere or for your family. Education is always a big thing as well. Make sure that you have your updates through CDC requirements, the updates on vaccines, and any emerging infections. A lot of times we get from the PA Department of Health, they will send out an HAI, which tells us in what area there are emerging infections. That's also important for us to know what's going on in our community, not just what's going on in our facilities. Waterborne concerns, Legionella is the main organism. However, there's also Pseudomonas and Acinetobacter. So we need to look at stagnant water areas, such as eye wash stations, any areas that had not been utilized for an extended period of time. If you've closed off a wing during the COVID times and then you're reopening, those areas need to be flushed. They should be tested to make sure that there's no bacterium in there. Any areas that are continuously wet, your pipes, faucets, water storage tanks, any decorative fountains, aerosolized water, air conditioners, nebulizers, humidified oxygen. Air conditioners are really one of the big problems when it comes to Legionella, because our air conditioners sit all winter without being used, and then come summer and we're turning them on and there's that cold air coming through, there is condensation. So we need to make sure that those are all cleaned appropriately. And another big one is ice machines. When you get down to it, a lot of ice machines, we don't get to the bottom of it every day because they keep making more and more ice. As you get down into the ice, there's a chance that there's water that may be contaminated. Water management must be based on national standards such as ASHRAE. It is formerly the American Society of Heating, Refrigerating, and Air Conditioning Engineers, plus the CDC, the U.S. Environmental Protection Agency, or APA. And the water management plans need to have an assessment to identify where Legionella and other opportunistic waterborne pathogens could grow and spread, measures to prevent the growth of opportunistic waterborne infections or control measures, and how to control them or monitor them. So what are we doing to try and avoid any water-based concerns? Are we monitoring those areas? Make sure that you have the appropriate documentation. Pest control, infection control and pest control work hand in hand. So our goal, of course, is to eradicate and contain common household pests. Make sure that you're aware of bed bugs, lice, roaches, ants, mosquitoes, flies, mice, and rats. Consider items brought in by residents and or visitors. That is one of the main ways that we end up, especially with things like bed bugs, because they're bringing in resident care items from the outside that may have been infested and then bringing it in. So do you have a process for that? Does it have to go through your environmental services first and maybe be decontaminated or disinfected? Those are things that need to be considered. Another one is residents like to keep food in their rooms a lot. And what does that attract? Well, most of the time ants, but it could also attract mice. So what is your policy and procedure for when a resident wants to keep food or drinks in their room? Do you have certain containers for them to utilize? These are all things that need to be considered for pest control. And remember that bed bugs are now a reportable infection. So your emergency preparedness plan, it focuses on your facility assessment. That's the big thing. Know that Appendix Z was updated on March 26th of 2021. The biggest thing was the emerging infectious disease planning, which also included obtaining of PPE, the monitoring of CDC guidance, who is doing that, who gets the updates, who makes sure that they look at this information on a regular basis, what to do with screening of residents, visitors, and staff, your social distancing, isolation, staffing shortages. If you have a staffing shortage because of infectious processes, What is your plan in your communication efforts? You also need to have a respiratory protection plan in place. So all of these things were added because of the COVID pandemic, but it has to all be a part of your emergency preparedness plan. I can also tell you that DOH surveyors in Pennsylvania have been asking for water management plans. So you also need to make sure that you have one of those in place. As far as the infection control plan for Pennsylvania, that link right there will take you to a very nice outline that explains what they would be looking for. It tells you what your infection prevention and control plan should include. It's very, very detailed. So that's a good reference for you to look at. And make sure that you have a committee together. This is not just for the infection preventionist. It is not just for your NHA. You really need to have an interdisciplinary committee be brought together for this, because everyone sees things from a different perspective. My biggest thing is infection prevention and control is for the safety of our residents, visitors, you as the staff member, your coworkers, and your family. Working in ICU for numerous years, I would laugh when my coworkers would tell me, when you get home, have an area where you strip down and take your clothes off before you enter the house, because you never know what you're taking with you. And they're right. You know, things look clean when you're washing it, but how many times did your scrub top rub up against something? Or, you know, how many times did something maybe spill, or, you know, you touched something, brushed up against something? These are all ways for us to transport infectious concerns throughout our facilities, but we can also take it home with us. So that's why, out of anything, it is just for everyone's safety. A good way to look at various things is germ juice. We used to use the black light and the germ juice and have them put it on their hands and then look at under the black light to see how dirty our hands really were. Another big thing are phones. The people that take their cell phones with them everywhere. Well, you have germs that are touching your cell phone, and how often do you actually disinfect it? Very, very rarely. You know, a lot of the younger generations have that cell phone with them always, in and out of resident areas, you know, touching it when they're eating, when they're drinking, when they're at home. Those are huge ways to take infections with us. So it really is an out-of-the-box approach to look at it. We all have the responsibility to try and prevent infections, but it is also for the safety of everyone involved. As we discussed, a big thing with our residents die because we bring infections into them. One thing I did not add to this, because I think it should be facility directed, but those staff members who are ill, at what time do you not want these staff members coming into the buildings? And I know this is very difficult because we're hurting for staff as it is, but you really should have guidelines as to when you're telling your staff, do not come into the building. Or when do you want your staff to wear a mask? As much as we hate wearing them, but if they have a certain sign or symptom, maybe they should be wearing masks. You really should have all of that outlined to make sure that you're doing the best for everyone involved. Here are some resources for you if you decide to use that. And here is my information. If you have any questions or need help with your plans, we are always willing to come and assist you with updating your infection control plan, your emergency preparedness plan. We do have respiratory protection plans that we can get for you. So you can always reach out to us and we can help you with any of that as well. Kim, I'm a little early, but do we have any questions?
Come one, come all. I did put a reminder in the chat to please submit any questions that anyone might have. I have not seen any come through, but as always, as a reminder, please reach out to Jennifer or myself. Her email is on the screen, and mine is kchalia@phca.org. Feel free to email us any questions that you might have after today's session. If you're a little camera shy, that is a-okay. We're happy to answer those off this platform. But Jennifer, thanks so much for presenting today. We appreciate you as always. And we will give everyone back 15 minutes of their day.
Thank you.
Thank you.